I'm Dave Shavelle from Long Beach Medical Center. I want to thank Dr. Bossum and others for asking me to participate. My topic today is extracorporeal life support ECLS programs, specifically related to their use in the cardiac catheterization laboratory. These are my disclosures. I do receive research support from B-Wave Medical and Avicenna, and I'm currently not on any speaker bureaus. We have three objectives. Number one, understand the poor outcome and limited treatment options for patients with out-of-hospital cardiac arrest and refractory VF and pulseless VT. Understand the indications and potential benefits of ECLS or ECMO for out-of-hospital cardiac arrest. And we'd like to also review the recently published ARREST trial and understand the potential implications for this new treatment approach. So let's start with what we know. Patients with STEMI benefit from primary PCI. Patients with cardiac arrest are critically ill and may have an acute coronary lesion as a cause for their arrest. We also know that patients with cardiac arrest that is complicated by STEMI benefit from emergent angiography and primary PCI. However, the benefits of emergent angiography and primary PCI in those with cardiac arrest and no ST signal elevation has been difficult to prove. Recent studies have compared early versus delayed angiography and haven't shown a clear benefit. ECLS or ECMO can be used to completely support the circulation in critically ill patients. And the use of ECMO ECLS has been described in multiple subgroups, including elective high-risk PCI, cardiogenic shock, and cardiac arrest, and specifically VF and pulseless VT. This is a summary of some of the recent studies looking at the use of ECMO for elective high-risk PCI. I'd just like to point out to the group that the final study, AUROR 2021, is a study we did at USC and Good Samaritan Medical Center. We included 15 patients undergoing elective high-risk PCI. Duration of support was approximately 1.8 hours. The other studies also similar, very small, retrospective single center using different devices, including CardioHelp, Centromag, and the Rotaflow system. An example of a case is shown at the bottom. This is a patient that was cannulated in the cath lab with percutaneous techniques, underwent high-risk PCI, and then the catheters, i.e. cannulas, were removed with the pre-close technique. The venous cannula was removed using purse string sutures. Over the recent years, there's been a significant evolution in ECMO devices. The devices are smaller and simpler. There is rapid setup and improved ease of use. These devices can be placed with percutaneous access techniques that are very similar to doing the TAVI procedure, that is double pre-close, angiography, and hemostasis post-procedure without the need for surgical cutdowns. You can also initiate these devices in the cath lab without the operating room staff and or perfusionist. And perhaps more importantly, you can maintain these devices for patients that need continuous support without perfusionists. So you can train your ICU and CC nurses to support these devices. In the lower left, I'm showing you one of the older ECMO circuits. In the middle is a CardioHelp device. It's a very small device. It weighs approximately 22 pounds. It can fit inside a helicopter to transport patients. And as I said, these devices are typically now placed in the cath lab. So what is eCPR? eCPR is extracorporeal cardiopulmonary resuscitation. And this is a technique where it involves a rapid use of VA ECMO during cardiac arrest when conventional CPR has failed to provide ROSC, or when repetitive rests occur without sustained ROSC. VA ECMO in this situation is used for complete hemodynamic support in order to treat the underlying cause, for example, a massive pulmonary embolism or underlying coronary disease. Doing eCPR essentially requires the use of mechanical CPR, either the Lucas device or the auto-pulse device. And this is essential because it facilitates cannula insertion. Recall that when patients are arrested and getting CPR, in order to put in the cannula is extremely difficult. And if you can use a Lucas device or auto-pulse device, you can maintain the mean arterial blood pressure approximately 55 to 60. Use of mechanical CPR also frees up the staff to focus on ECMO, continued resuscitation, that is acid-base management, electrolytes, blood sugar management, and also the performance of emergent angiography and PCI. This is an example of a patient in the cath lab with the Lucas device doing angiography. Angiography is very difficult. For those of you that have done this, you know that it's very difficult. The views are suboptimal. It's very hard to get the Lucas device out of the field of view, but it can be done. Let's talk a little more about cardiac arrest and ROSC. And this is a nice way to divide these patients. This is from a paper from Yamanopoulos in Circulation 2 years ago. We can talk about those with no ST segment elevation, those with ST segment elevation or new left bundle, and those with refractory ventricular fibrillation or pulsus VT. And if you look at those with no elevation, significant CAD is present in up to 50%, acute lesions in up to 35%. Those with ST segment elevation or new left bundle will have significant CAD in up to 95% and an acute lesion in up to 80%. And finally, those with refractory VF or pulsus VT will have significant CAD in up to 85% and an acute lesion in up to 65%. Patients with out-of-hospital cardiac arrest have extremely poor outcome. Unfortunately, VF or pulsus VT, so-called shockable rhythms, only contribute to about 20 to 30% of those with cardiac arrest. 60 to 80% of those with a favorable neurologic outcome will present with VF VT. And we know the outcome of those presenting with a shockable rhythm is much better compared to those presenting with a non-shockable rhythm. Only 25 to 30% of those with VF or VT survived a hospital discharge with good neurologic outcome. And as we know, over the last 10 years, there's really been a minimal change in outcome in those with cardiac arrest. So we need new treatment options. This is looking at all the factors associated with improved outcome in those with cardiac arrest. Witnessed arrest, bystander CPR, short CPR duration, less than 30 minutes, younger age, a STEMI on EKG, or the ability to do successful PCI. All of those factors associated with improved outcome. But the most favorable factor, even more than age, is the presence of a shockable rhythm. How common is e-CPR? If we look at this ELSO International Registry from July of 2016, 14% of adults that went on ECMO, the indication was e-CPR. So it's not extremely common, but then again, it's not uncommon, 14% of the cohort. In recent years, we've learned a lot about this concept of e-CPR. I've listed here 7 retrospective studies looking at survival with good neurologic outcome and looking at this time from collapse to the establishment of ECMO or e-CPR flow. And the time that you want to achieve is 60 minutes. If you can achieve collapse to e-CPR time of 60 minutes or less, it's associated with improved survival and improved neurologic outcome. And that is extremely difficult to do. This is a summary of some of the recent e-CPR studies, and I'll just point out a few. The first study here by Stubbs, 2014, this is a CHEER study that was published in Australia, only 26 patients and only a cohort of 11 with out-of-hospital cardiac arrest. But in-hospital survival in that out-of-hospital cardiac arrest cohort was 45%, which was much better than we'd seen in recent years. I'd also like to point out the Prague study, an ongoing study. It's enrolled currently approximately 170 patients, a randomized study of using e-CPR. And we'll talk about the arrest study that was published last year in Lancet, included 36 patients randomized to usual care or ECMO, and the primary endpoint was survival to hospital discharge, 43% in the ECMO group and 7% in the usual care group. So let's look very quickly at the arrest study. As I said, 36 patients, inclusion criteria, age 18 to 75, refractory VF pulsus VT, 3 shocks with no ROSC, Lucas device in the field, and a short transport time less than 30 minutes. 30 patients were included, 15 randomized to standard of care, 15 to ECMO, and the primary endpoint survival hospital discharge. I'd also like to point out a few other important points. This study was funded by NHLBI. There was a data and safety monitoring board that actually stopped the study early because of benefit in one of the 2 treatment arms. All patients were taken to the cath lab for ECMO, and they had predefined stopping rules. There was 3, end-tidal CO2 less than 10, PaO2 less than 50, or a lactate greater than 18. If you had one of those 3 stopping rules, the patient was declared dead and they were not cannulated for ECMO. If you didn't, you cannulated for ECMO, you did emergent angiography, and then PCI. And these are the results. We're showing survival on the y-axis and time on the x-axis, and you can see survival in the ECMO group was 43%. In the standard of care group, it was 7%. That hazard ratio was 0.16 with a p-value that was highly significant at 0.0001. The other thing I'd like to point out is those curves are flat over time. So if you were in the ECMO group and you survived a hospital discharge, your outcome over time up to 210 days was very good. So if you can survive that event, you're going to do well over time. This is a case we did at USC approximately 2.5 years ago, 38-year-old male, cardiac arrest, refractory VF, defibrillated approximately 20 times. He came to the cath lab. He was in VF arrest. You can see his rhythm at the bottom here was VF. He was cannulated for ECMO. He was flowed for about 1 minute. He was defibrillated and he went back into sinus. His LAD was occluded. He underwent angioplasty and stenting with a good result, and he remained in sinus rhythm throughout the rest of his hospital course. These are two of our phenomenal cath lab nurses, Tuette and Diana, that supported the case. We did this case with a CardioHelp device. 4 days later, one of my favorite fellows, Leah, called me and she said, "Hey, Dr. Shavelle, grab Dr. Mara, come over to the CCU. We just extubated the patient that was in cardiac arrest. This is a grateful patient, a grateful wife, 2 young kids. This is my former partner, Dr. Mara, and myself, and this is what Leah said was a really good day." And I'll just point out that for any of you that have done this with ECMO and saved these patients, you tend to be believers, and you just need one case to be a true believer in this technology. So going back to the arrest study, logistics are extremely difficult. You need these rapid response times. You got to get to the hospital quick. You got to get them on ECMO quick. You have to place these cannulas in the setting of a low blood pressure or no blood pressure. You need fluoro, ultrasound, contrast, focus, and prayers because it's very difficult to do. These patients are extremely complicated. If we looked at data from the arrest study, the arrest trial, time to extubation was 9.5 days on average. ICU stay was 21 days. Hospital stay was 25 days. And 42% of the patients got more than 3 units of blood. So these are sick patients and they stay in the hospital a long time. Let me just end with a brief discussion on the EROCA trial. This was just released. It has not been published in manuscript nor abstract form. This was a single center study at the University of Michigan. Cardiac arrest, similar to the arrest trial, but a little bit different. Transport time less than 30 minutes. You could have VT of VF, but you could also have witnessed PEA or asystole. You had to have persistent arrest after 1 shock, not multiple shocks. And the primary endpoint was time from 911 call to ED arrival. They were basically trying to figure out, could we get these patients to the hospital quickly? So they enrolled 15 patients, 12 were in the expedited group, that is rapid transport, evaluate for ECMO, and 3 were in standard of care. Of the 12 that were in the expedited group, 5 of those 12 got ECMO. Average transport time was 32.5 minutes. Only 42% met that 30-minute criteria. ED arrival to ECMO was 32.4 minutes. The goal was 30 minutes. Only 60% of the patients met that criteria. And unfortunately, none of the patients out of that 12 cohort in the expedited group, including the 5 that got ECMO, survived. In the standard of care group, 1 of the 3 survived, 33%. As some of you know, we are doing a small pilot in Los Angeles County involving 3 centers, UCLA, Cedars, and USC. Very similar to the arrest trial, age 18 to 70, cardiac arrest, refractory VFVT, 3 shocks, continued ROSC, amiodarone 300 milligrams, and a transport time less than 30 minutes. All patients are getting mechanical CPR Lucas in the field. They're then routed to one of these 3 centers if their transport time is less than 30 minutes. On hospital arrival, they're being evaluated for ECMO, emergent angiography, and PCI, and we adopted the same stopping rules that they use at the University of Minnesota. So let me summarize. Refractory VFVT, high prevalence of acute coronary lesions, outcome is extremely poor. ECMO can be used in this subgroup for complete hemodynamic support. Time from cardiac arrest to ECMO is related to outcome. The time is thought to be 60 minutes or less. That is, from the time you arrest to the time you are cannulated should be 60 minutes or less for a good outcome. Observational studies do suggest a benefit for this concept of e-CPR. However, the 2 randomized studies that are out there, the arrest study, as I showed you, was positive. EROCA has not been presented nor published. It was a smaller study, 15 patients, and in general, it was a negative study. There are multiple ongoing studies, a study in France, a study in Netherlands, and then a very nice study in Prague that's being done. and then our small pilot that we're doing in Los Angeles County. So let me thank you for your attention. And again, I appreciate being asked to do this lecture.